Assigned to me is cell-based regeneration strategies in lumbar disc and its limitations. Well, I'll give my introduction. I am Professor Dr. Manish Khanna, former head of orthopedics and in charge orthobiologics in Autonomous State Medical College, Ayodhya. But now I am working in Lucknow as a Dean Academics to New Institute of Medical Science, which is now called as Dr. KNS Mims Barabanki. I am chairman to Indian Stem Cell Study Group Association and chair to Educational Day World Orthopaedic Association, SICOT. So without wasting time, I welcome you all on behalf of Indian Stem Cell Study Group Association and Indian Stem Cell Study Group, a Orthopaedic regenerative group, which is devoted to fellowship program in orthobiologics for orthopedic surgeons. So I think in last 1 hour, we are agreeing to the point that future of the medicine surgery is regeneration. So definitely yes, coming to this disc regeneration, after just saying this line, that spinal cord regeneration is still in a research form for all of us by using mesenchymal stem cell or bone marrow cocktail. Now the terminology has to be very much clear. What is stem cell? So stem cell, characteristically, when we are saying mesenchymal stem cell, then it is to be said as stem cells. Otherwise, what we are using is PRP or bone marrow concentrate, a bone marrow cocktail, which is a mixed population of heterogeneous cells. Degenerative spine disease is really a problematic situation for all of us. And if you see across the globe, you can see this pink area. I mean, it's in the USA, it is a debilitating condition. I mean, it's a situation which is very troublesome. In coming decades, it will be worsened. And as all our surgeons here, spine surgeons here, so need not to tell much about the nucleus pulposus or the annulus fibrosus, but the most important thing is to remember is it's not always when the nucleus pulposus coming out of the disc, that is a herniated disc, the symptom comes. Sometimes the symptoms are even there when the degeneration is on. Radiological appearance of the disc degeneration is definitely shrinkage and the losing of the height, but in MRI, the things may be picked up little early also. So whenever you are placing a BMAC or a PRP or MSC, whatever in the disc area, under the fluoroscopic guidance, the results will come. Pain relief will be there first, which is again subjective finding, but what we require is a evidence-based medicine, and that we'll try to work up in this coming 6 or 7 minutes. Now, similarly, whenever we inject MSCs, maybe autologous or allogenic, the idea is to restore the cell structure and the hydration, the nucleus pulposus cell structure and the hydration. So while we inject it, it reconstructs the nucleus pulposus matrix, that's very good, and it promotes the tissue regeneration, thereby reducing the nociceptive disc pain. That's why the patient have a pain relief, probably slowing down the catabolic process. Finally, rebuilding of nucleus pulposus. So this is the hypothesis on which we try to work. Now, we all know that the MSCs secrete the anti-inflammatory molecule, the platelets secrete, and that is why the inflammation is reduced whenever we inject some material in the disc. These growth factors which are produced by platelet or MSC, they may restore the integrity of the extracellular matrix, which is very important in a degenerating intervertebral disc. So ultimately, whenever you're placing a stem cell, whenever you're placing a growth factor in the form of PRP, ultimately the apoptosis of the nucleus pulposus cells should be decreased, proliferation of the cells should increase, some catabolic activity should come down because of the decrease in inflammatory cytokines, and this is how a disc can be regenerated or can be prevented from degeneration. And as I've already mentioned, to assess the regeneration of the disc, what we require is a good elevated T2 signals in MRI, which is a proof of little bit of good improved hydration, restoration of the extracellular matrix. But whenever the studies are being done since decades, this is being reflected? No, it's not always been reflected. As far as the PRP has been considered, so it has been used in the discogenic log pain in a lot of the studies since 2011. I've just placed here a study from Asian Spine Journal in 2017 where the intradiscal injection of autologous platelet-rich plasma was being given. And this was a preliminary clinical trial. The results were enthusiastic. So this was data which was taken from only 14 patients. Average follow-up was of 10 months. So in all these studies which we'll be discussing, sometime 10 months, sometime 8 months like that. The best part was the VAS score significantly decreased and it persisted to that extent for next 10 months. So that was a good thing. Now, this is a very busy chart which is showing a comprehensive review of PRP in low backache. So now 2016, 2017, 2016 by Tuikliu, this study which is randomized controlled trial. So in some studies, again, as explained earlier, a period of 6 months was being taken, sometime period of 3 months was being taken, sometime even for 90 months was being taken. In all these cases, 1.5 to 2 ml of PRP was being injected. And as mentioned, the pain was significantly being reduced. And but the question is whether these randomized placebo-controlled trials were able to provide a disc regeneration radiologically. So it was again a gray area to be commented right now. Then some clinical trials are still being on, some are being completed, some of the cases are being recruiting. So the first one is still being in the recruiting stage at Utah from United States, at the same time in California, where the platelet-rich plasma and bone marrow aspirate were being used in this data. Again, 1.2 ml of PRP plus 1.2 ml of bone marrow cocktail. 60 patients are still in the recruiting stage. 2 trials have been completed where the intradiscal injection of platelet-rich plasma for discogenic pain was being given. One was a multicentric randomized controlled trial. So we are waiting for enthusiastically for the results to be out, but the preliminary data which is being available to us show a significant pain reduction. Sometime some hope in radiological parameters for increasing in disc structure, integrity. But if you say a wonderful disc increase in the space, it still is a dicey situation. So these results are promising. Further studies are needed to define the subset of the particular of the patients which are to be taken, which are to be subjected for intradiscal treatment. The problem is there is no standardization of using a PRP. The variability in the PRP preparation, the amount, there are so many things which are required for establishing any particular proof. Now, this was a study which was a review article done by Indian Stem Cell Study Group few years back, in which we did a review article about the intradiscal use of platelet-rich plasma, whether it is having any beneficial role in the management of lumbar disc diseases. So what we found was lack of conclusive evidences while using a PRP. There may be some beneficial effect in controlling the pain, which will be better than using a dipomedrol, truly speaking. But the structural improvement, we were not able to find any structural improvement. Then another use of PRP, a review article was being published when spinal fusion, when the spinal fusion is being done, sometimes the platelet plasma has been used. So this was a systemic overview of the meta-analysis. And what we concluded is the effectiveness of the PRP as a biological agent in augmenting spinal fusion is limited. Current evidence does not suppose the use of PRP as a adjuvant for a spinal fusion. So if you do it, if you don't do it, not much difference.